Sir, live started.
Okay, Sai, you can start.
Yes, sir. Uh, Good morning, everyone. I am Dr. Mohan Sai. I am a final year senior resident doing DM critical care medicine at AIIMS Jodhpur. I would like to thank Gansham sir and Srinivas sir for giving me this opportunity. Today, I would like to present a seminar on transcranial Doppler basics. So, ma'am is my teacher. She is Tilaka Muttaya ma'am. And while teaching us at AIIMS New Delhi, she has shown this slide. And all she says is that teaching is to create curiosity. So with this, we go ahead and we would like to ask what is a common thing between these two images. So one is a lung ultrasound and second is a transcranial Doppler. So the common thing between these two images is a paradox where people thought that it is, I mean, like we won't be able to use ultrasound on the lung and skull because air reflects ultrasound. Then skull will not allow ultrasound to penetrate through its thick bone. So it has always been mystery that lung ultrasound and transcranial ultrasound or Doppler, they have remained paradox unless and until Daniel Lichtenstein uh, uh, has created a way to see lung ultrasound, as well as Rune Aslid has created a way to see transcranial Doppler and how we can go forward with this. So if we have to look at transcranial Doppler in one slide, so the transcranial Doppler, we have an opportunity in terms of adversity. Skull is a thick bone through which ultrasound waves cannot penetrate in, but then we have an opportunity. That opportunity is thin portions of adult skull, which we call them as insonation windows, and we target intracranial arteries through those insonation windows. We use an instrument called low frequency ultrasound probe with a circular footprint, and it works on Doppler shift and a new technology called pulse wave Doppler. By using this instrument, there is a spectral waveform that comes out and we analyze it. By analyzing it, we have velocities, peak systolic, end diastolic, and mean flow velocities. By looking at how these velocities are, how the waveform is, we would like to apply this particular analysis of spectral waveform in various pathologies of the critically ill patient having acute brain injury. So if you would like to go ahead more about transcranial Doppler, so this is the first angioscan machine used by ASLID in doing transcranial Doppler. So in 1982, first paper has come on transcranial Doppler by Rune Aslid, and he has described how he has done the unthinkable back in those days. So now TCD is being used routinely at the bedside for rapid assessment and monitoring of cerebral hemodynamics. Also a part of multimodal neuromonitoring in critically ill patients with acute brain injury. Also, it has been a game changer in the management of cerebrovascular disease, especially subarachnoid hemorrhage. Rune Aslid's main thought process was to identify vasospasm before delayed cerebral ischemia or infarct occurs. So, with these thoughts, he has worked and developed transcranial Doppler. Not just subarachnoid hemorrhage, it has applications in a lot of other cerebrovascular diseases. And innovations continue to happen, and transcranial Doppler, which was introduced by ASLID, has been improved. So there were new technologies such as power motion mode and transcranial color-coded duplex sonography, which has helped us to do it in a much better way. So now we have 4 insonation windows. So the A window, the image labeled A is a transtemporal window. Image B labeled is transforaminal or suboccipital window. Image C is submandibular window, and image D is a transorbital window. With the help of these insonation windows, we would like to look at the intracranial arteries. But then before we look, what are its basics? So image A shows internal carotid artery in the extracranial portion, how it is like giving the branches in the intracranial circulation. So it all starts with common carotid artery, then it gets divided into external carotid artery as well as internal carotid artery. So there is a bulb, there is a dilatation which is called as a carotid bulb. So this internal carotid artery travels through the neck, then enters into the skull, and doing so, there is a carotid siphon. So there is a S-shaped structure called as carotid siphon, and carotid siphon gives a branch called ophthalmic artery to the eye, and this carotid siphon continues as a terminal internal carotid artery before it gets divided into middle cerebral artery and anterior cerebral artery. Although there are many branches, but for us to understand transcranial Doppler, these are important branches. Whereas in the B image, we have vertebral artery, two vertebral arteries, right and left, joined together to form basilar artery. And this basilar artery travels on the midbrain, and at the end of the midbrain, it gets divided into posterior cerebral artery, two posterior cerebral arteries. So now the third image we are looking at is a circle of Willis. So circle of that, the posterior circulation driven by basilar artery and posterior cerebral arteries gets connected to the anterior circulation, which is driven predominantly by middle cerebral artery and anterior cerebral artery. So you can see that the anterior communicating artery, so this is the anterior communicating artery, and so it helps in bridging right circulation and left circulation. So right hemispheric circulation and left hemispheric circulation in the anterior part. So it is combined by anterior communicating artery connecting two anterior cerebral arteries, whereas posterior communicating artery bridges anterior circulation and posterior circulation. So with this brief knowledge on intracranial arteries, we go ahead and look at the machine. So image A, we have a machine with the monitor. Then B is that low frequency ultrasound probe with a circular footprint. And C is, C is a headset. Headset is a new addition to the machine. So this headset can be applied on the skull, and it can be used for a continuous monitoring. So as we can see, the Doppler shift and the pulse wave Doppler. So the pulse wave Doppler helps in localizing the artery, and where we want to insonate a particular artery at particular location, the pulse wave Doppler helps. So we apply the probe to the insonation windows, then ultrasound wave generates. So the machine uses pulse wave Doppler, tries to sample or insonate the intracranial arteries, and then we get a spectral waveform. So apart from the power, apart from the pulse wave Doppler, we have something called as power motion mode. So power motion mode is a new advancement on top of Rune Aslid's initial TCD machine, where en route to the ultrasound beam, so whatever intracranial arteries that come, so it all will be sampled and it will be shown in a display. So we can actually go from one artery to another artery. So this helps in easy localization of intracranial arteries, and it gives us a better picture. So power motion mode is what you can see here. So this is the power motion mode. And now we get a spectral waveform by doing so. So this is the spectral waveform. The topmost corner is the spectral waveform, and the bottom is the power motion mode display. So when we analyze this spectral waveform, so we understand that there is a sharp upstroke and there is a peak systolic velocity. Then as it comes down, so it comes down in a gradual manner, and we have a dichrotic notch. So also we observe that the velocities do not touch the baseline, and there is a good amount of end diastolic velocity. So this is a characteristic of cerebral circulation where there is a low resistance circulation in the brain. So it helps in better circulation in the brain, giving the brain the nutrients and the oxygen even in the diastolic phase. So this is in contrast to the peripheral arteries where there is a high resistance circulation. So now to understand, like once we get peak systolic, end diastolic, and mean flow velocities is an average of PSV and peak systolic and end diastolic waves. So once we get these three velocities, so we have a numerous applications like diagnosis and monitoring of vasospasm, non-invasive assessment of intracranial pressure, diagnosis of cerebral circulatory arrest. We can look for stenosis and occlusion of intracranial arteries. We can look for cerebral microemboli. We can assess vasomotor reactivity as well as cerebral autoregulation. So with this, we would like to dwell deep into transcranial Doppler and try and understand how to do it in a better way. So as usual, we start with our insonation windows, our opportunities to look into the intracranial arteries. So this transtemporal window, the patient will be supine and the head is in neutral position. The transducer is kept in the temporal aspect of the skull, kepler to the zygomatic arch and anterior to the tragus. So here, what we can see is that if this is if this is the tragus, this is the zygomatic arch. So we would like to keep our probe as near as possible to the tragus and just above the zygomatic arch. So by doing so, we would like to uh, the ultrasound beams directly get aligned to the base of the brain, midbrain, and we would be able to insonate terminal branch of internal carotid artery, anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. Now, the most important thing we need to understand is uh, we need to identify these arteries based on various parameters. So the first parameter is where is the probe placed. Second parameter is at what depth we are getting a spectral waveform, and whether the spectral waveform is above the baseline or below the baseline. So then you know what are its velocities. So based on lot of things, we would like to identify a artery, whether it is a middle cerebral artery or anterior cerebral artery. So that we would see in later part of the discussion. So first about transtemporal window, patient is in supine position, then head in neutral. The probe is kept as near as possible to the tragus, anterior to the tragus and kepler to the zygomatic arch. With this, we will be able to identify terminal ICA, MCA, ACA, as well as posterior cerebral arteries. So then we come to the next window. So it is a suboccipital or transforaminal window. And now, if possible, patient can be having a lateral decubitus position. This is not compulsory. If it is possible, it can be done. Otherwise, we can try and turning the head to one side and try to give a slight flexion. And then we can get this window. So transducer is placed on the nuchal crest slightly off midline and is angulated in superior and medial directions. So with this transforaminal or suboccipital window, we can localize vertebral artery and basilar artery. Then comes to the submandibular window. In this, patient is lying supine with head in slight extension. The transducer is placed on the angle of mandible and is angulated superior and medially. Here we can use this window to localize extracranial part of internal carotid artery. Now the transorbital window. So in this transorbital window, the patient is supine with the head in neutral position. The transducer is kept on the orbit and it is angulated in the inferior and medial directions. With this, we can localize ophthalmic artery and carotid siphon. So carotid siphon is that S-shaped structure which is giving ophthalmic artery and finally proceeding into the terminal ICA, giving rise to ACA and MCA. So with this knowledge on windows, now we would like to proceed and try to identify the arteries. So the first artery, the significant information is shared by middle cerebral artery. So it is a saying that if you are a beginner in TCT, you need to try and get at least middle cerebral artery, which is of course many a times easily achievable. So middle cerebral artery can be identified through transtemporal window, and the depth of insonation is 30 to 65 mm. Like you can see here, the depth is 58 mm. So at a depth of 30 to 65 mm, we get a spectral waveform which is above the baseline. So the flow in relation to the transducer is, the flow is towards the transducer, and we get the spectral waveform above the baseline. And here the mean flow velocities are 55 plus or minus 13 centimeters per second. It can vary, but this is an average. Now we look at anterior cerebral artery. Again, we use transtemporal window, and in this, at a depth of insonation 60 to 75 mm, we can see the depth is 75 mm, 74 mm here. So the flow in relation to the transducer is away. So the flow is away to the transducer, and with that, spectral waveform is below the baseline, and the mean flow velocities is slightly less than the middle cerebral artery, which is 50 plus or minus 11 centimeters per second. So in order to get anterior cerebral artery, what we need to do is to keep the probe at middle cerebral artery, where we get middle cerebral artery, and try to angulate it slightly anterior. So by putting the probe and slightly angulating anterior, we would get anterior cerebral artery. Then the posterior cerebral artery. So we use transtemporal window, and we need to angulate the probe slightly posterior, um, uh, and at the depth of insonation 55 to 75 mm. We have posterior cerebral artery can be divided into two components, proximal and distal segments. So the proximal segment, the flow is towards the transducer, and hence for proximal segment you would get a flow above the baseline, whereas distal segment, the flow is away from the transducer, so you get the flow below the baseline. So the mean flow velocities, always anterior circulation has a higher velocities, posterior circulation will have a comparatively lower velocities. Here the mean flow velocities are 40 plus or minus 10 centimeters per second. So now here you can see that at a depth of 60 mm, we have got a signal. The signal is spectral waveform is above the baseline with a mean velocities of 32 centimeters per second. So this is proximal segment of posterior cerebral artery. Whereas in the next image, we have spectral waveform, which is below the baseline at a depth of 65 mm. And this is distal segment of posterior cerebral artery. So through transtemporal window, we have got middle cerebral artery, anterior cerebral artery, and posterior cerebral arteries. Then we would like to go ahead with the suboccipital or transforaminal windows. So like in this vertebral artery, in order to insonate, so vertebral artery and basilar artery almost occurs at different depths at similar location. So it is just that we need to tilt the probe more superiorly to get basilar artery, and we get basilar artery in slightly higher depths. So coming to vertebral artery, it is the insonation window is suboccipital or transforaminal window. The depth of insonation is 40 to 70 mm, and the flow is away, and the mean flow velocities is 37 plus or minus 10 centimeters per second. Whereas basilar artery, you find that almost it is similar, just that the depth of insonation, so the depth at which basilar artery is insonated is at 80 to 105 mm. So in the subsequent images, you would see that at the transforaminal window, we got a spectral waveform which is below the baseline, and it is occurring at a depth of 75 mm, and which has a mean flow velocities of around 29 centimeters per second. So this we take it as a vertebral artery. Whereas in the second image, you see that similar spectral waveform with flow below the baseline is happening, but it is happening at a depth of 95 mm. So the second image is a basilar artery. Now with the transorbital window, we would like to insonate ophthalmic artery and carotid siphon. So ophthalmic artery through transorbital window is identified at 40 to 50 mm depth. The flow in relation to the transducer is towards the probe. Mean flow velocities is 21 plus or minus 5 centimeters per second. Whereas carotid siphon, the insonation window is through transorbital window. Depth of insonation is 58 to 65 mm, slightly deeper than the ophthalmic artery. And the flow is variable. So because the carotid siphon is S-shaped, so you might get a flow which is above the spectral waveform, above the baseline, below the baseline, and a biphasic flow as well. So, but how do we differentiate ophthalmic artery and carotid siphon is that ophthalmic artery has a high resistance waveform, whereas carotid siphon has a low resistance waveform. So because ophthalmic artery is entering into the eye, the profile of the velocities changes because of the course into the orbit, whereas the carotid siphon enters into the skull and the low resistance circulation remains the same. So here we can see that the first image at a depth of 45 mm, we get a spectral waveform which is above the baseline, which is showing mean of 17.2 centimeters per second. Here, compared to the second image, the diastolic velocities are less, peak systolic velocities are less. Whereas in the second image, we have a spectral waveform which is above the baseline at a depth of 60 mm. And comparatively, this is looking more like a low resistance spectral waveform because the end diastolic velocities are much preserved. So by this way, we differentiate ophthalmic artery and carotid siphon. So now we usually do not do use submandibular window routinely, but say that if a patient is having vasospasm and we would like to differentiate vasospasm from hyperemia and we would like to calculate Lindegard ratio. So that is when we would like to use submandibular window and try to insonate internal carotid artery, extracranial portion. So we get mean flow velocities from middle cerebral artery of the same side, mean flow velocities of extracranial part of internal carotid artery. We divide them and we get a Lindegard ratio. So whenever we are suspecting vasospasm and the velocities in the middle cerebral artery are very high, so that is when we would like to do a submandibular window and insonate extracranial internal carotid artery. So it is usually we get it at 35 to 80 mm depth, and it is the flow is below the spectral waveform is below the baseline, and the velocities is 34 plus or minus 9 centimeters per second. Here we got it at much shallow depths, but we usually get it 35 to 80 mm depth. It depends on how we are angulating the probe. So with this, we have insonated almost all the major important arteries. So now we can say that what we need to do is we need to keep the patient in supine position, attach the hemodynamic monitors, because we understand that cerebral circulation doesn't happen in isolation. So many a times it is coupled with the cardiovascular hemodynamics. So it is very important for us to have a blood pressure monitor, saturation, ECG attached to the patient, and we interpret these waveforms in relation to these hemodynamic variables. So once the patient is supine, monitor is attached, TCD gear is to be applied, monitor, transducer and headset. So then how do we do it? So how do we do it is that we need to follow the course of blood flow in major intracranial arteries, say in each major branch, say in MCA. So if we take MCA, we need to at least 2 key points per artery. So, and in that, if at all we get any abnormal waveforms, we need to store them. And when we get multiple velocities at the same point, we need to measure the highest velocity signals at each point. Now, the sequence of TCD examination is usually transtemporal, transorbital, and suboccipital. And submandibular window is examined when there is suspicion of vasospasm. So in transtemporal approach, we commonly first look at MCA at 50 mm. Then we would like to go up till 30 mm, try to insunate the distal segments of MCA, say proximal M1 segment, M2 segment. They would occur at much lesser depths. Then once this insunation of MCA is done, we would like to go down beyond 50 mm, try to insunate terminal ICA, and we would like to insunate anterior cerebral artery. So once we are done with the anterior circulation, we can probe at depths beyond 50 mm. We can insunate posterior cerebral arteries. So this is how transtemporal is done. So the idea is start at the depth of 50 mm, you go up to 30 mm, and then try to cover MCA. So you start with the proximal branches of MCA, you cover the distal branches as well. Then you go deeper to 50 mm where your terminal ICA lies, your ACA lies. So you measure terminal ICA and ACA. And once these are done, you can look ahead for posterior cerebral artery. So now after this transtemporal approach is done, we do transorbital approach. We need to be cautious that the power of the probe should be decreased to 10% so that the ultrasound waves will not impact the intraocular structures. So we can get ophthalmic artery at a depth of 50 mm, and beyond 50 mm we would get a carotid siphon. So that 50 mm we can take it as a benchmark in transtemporal and transorbital approach. In suboccipital approach, so we can start slowly from 40 mm depth, and we can go ahead increase our depths so that we get vertebral artery at around 40 to 75 mm depths, whereas we get basilar artery at depths above 75 mm till 100 mm. So then submandibular approach. So we need to insunate and get intracranial artery, internal carotid artery, but sometimes we get external carotid artery signals. How do we differentiate this? External carotid artery has a high resistance waveform. It supplies blood to the facial muscles. So there are a lot of branches. So that is why there is high resistance waveforms. Whereas internal carotid artery has a relatively simple approach, and it is connecting with the brain, and there is a low resistance waveforms that we would appreciate in internal carotid artery. So with this, resident thinks it is so wonderful to do transcranial Doppler, and he decides to do it, but then the department doesn't have a TCD machine. So what do we do now? We don't have a traditional TCD machine. So that is where the next part comes. So this is transcranial color-coded duplex sonography. So apart from the traditional TCD machine, in case we don't have it in our departments, we can use the routine ultrasound machines, which is having a phased array probe. We can use these ultrasound machines, use a phased array probe. And the advantages of it is, now in the traditional TCD machine, we are actually identifying arteries based on indirect variables, like which window, then, at which depth it is happening. And then, what is the waveform? Is it above or below? So with all these indirect variables, we are trying to identify the arteries. Whereas in transcranial color-coded duplex sonography, we have a color Doppler. So we have a B mode. So we can actually visualize the parenchyma. We can put a color Doppler. Then we get vessels. Then we can identify those vessels based on its relationship with the nearby structures. So that makes our identification easier and more accurate. So, but then the one disadvantage is that there is no continuous monitoring available to this. So in traditional TCD, we have a headset, so we can use it for a continuous neuro monitoring. Whereas for this machine, so such a technology doesn't exist. Now, okay, so I always tell my juniors that in order to get a transtemporal window and in order to get the vessels identified, we need to catch a butterfly. So now what is a butterfly? The butterfly is the midbrain. So as we all know that the circle of Willis is at the base of the brain, and the base of the brain, the midbrain is a location in and around midbrain. We would get these vessels. So here you can see that this heart-shaped structure or a butterfly-shaped structure is a midbrain, and in front of it there is a temporal bone. So what happens is basilar artery comes like this. It divides into posterior cerebral artery, posterior cerebral artery. Now this is the temporal bone. So at this temporal bone, at the anterior clinoid process, this terminal ICA enters into this and then divides into middle cerebral artery and anterior cerebral artery. So now we would like to see a video on it. So this is the midbrain. I am showing it here. So here we can see that, so this is the midbrain, and at the midbrain, the basilar artery divides into posterior cerebral artery, ipsilateral, contralateral. Now this is the temporal bone. So this is where there is a division of MCA, that the flow is coming towards the probe. So here the probe is, so it is coming towards the probe. So that is why the signal is red and the waveforms are above the baseline. Whereas you can see that anterior cerebral artery is going away. So it is going away from the probe. So that is why you're getting a signal of blue, and the spectral waveforms are below the baseline. So now we would like to play this video, and we can see so how the branches appear. Moving on to the next one. So if we do a foraminal window, so we get vertebral artery and basilar artery. So as we have discussed, so two vertebral arteries, so one vertebral artery, another vertebral artery together joins to form a basilar artery. So now this is a submandibular window. So previously, say that, in the traditional TCD, we would like to differentiate ECA and ICA based on the profile of the waveform. So high resistance waveform is external carotid artery and the low resistance waveform is internal carotid artery. Whereas here we can actually identify the vessels. So you can see that this is a common carotid artery coming, and internal carotid artery lies posterior inferior to the external carotid artery. So this is external carotid artery, below it posterior inferior, and we get a ICA. So you can see a nice pulsating waveform. So this is ECA and ICA arising from the common carotid artery. So now, not just interrogating or insonating the arteries, we can also look at the um, anatomy of the brain. So it is very wonderful that, although there is a limited view about the anatomy of the brain, but it is wonderful to see brain through ultrasound. So we always, are used to see through CT scans and MRI, but it feels wonderful to see through ultrasound. So as we know, our first, we always look at midbrain. So midbrain, uh, when the probe is placed at the transtemporal window and we get the midbrain, all you need to do is to tilt it up. So if you slowly tilt up, so then you would get a third ventricle. If you slowly tilt even more up, you get a lateral ventricle. So here we try to label the hypoechoic structures in a anti-clockwise manner. So the first would be the midbrain, the second would come as a third ventricle, and third would come as a left ventricle. So this is the midbrain. Now this is the third ventricle. So this is the lateral ventricle. I'll be playing it once again. So this is the midbrain. So we are tilting the probe little up and we are getting a third ventricle, and we are tilting it even more up and we are getting a lateral ventricle. Okay. So now we would like to see that the third ventricle is actually opening into lateral ventricle. Although this is not possible in a normal uh, participants, but in people where there is hydrocephalus, the anatomy is very beautiful. So here we would see that this is third ventricle, and third ventricle connects to the lateral ventricle through foramen of Monro. So you can see that actually it is opening like a, it's opening like a hands, okay, into the lateral ventricle. You would see here. So this is foramen of Monro. It is opening into the lateral ventricles. Here you can observe that, the hands are opening up into the lateral ventricle, which is, the hands are foramen of Monro. So you can appreciate this. The lateral ventricles will have frontal horns and occipital horns. So this is frontal horn, you can see. So these are the occipital horns of lateral ventricle, the posterior part of the lateral ventricles. And here, in the middle of this anechoic structures, you would find a hyperechoic structure. So that hyperechoic structure is a choroid plexus. So I'm playing the video. So this is your occipital horn of lateral ventricle. And in that you would see a hyperechoic structure that is coming in, that is choroid plexus. Now you might be wondering, why we would be looking at all this anatomy and all. So, next time we talk about the applications of transcranial Doppler, we would understand that, all this information is useful in, monitoring and looking at neuroworsening. So now, all this is done. So with the traditional TCD machine, we know how to identify a insonation window, how to insonate intracranial artery. Also, we have looked at transcranial color-coded duplex sonography, how to look at the structures, how to identify the blood vessels. Now, once we know how to use these two machines, both of them gives a common entity, that is spectral waveforms. And once we analyze spectral waveforms, we get plethoric of information. So the basic rules are same. The insonation windows are same. Then, insonating the arteries is same. Spectral waveforms is same. But we need to know the rules of it, how to interpret. So as we all know that the cerebral circulation is a low resistance circulation. There will be a sharp systolic upstroke, a dicrotic notch. The diastolic velocities do not reach baseline. It is heavily influenced by a lot of factors, local and systemic. So the local factors would include stenosis, occlusion, collaterals, vasospasm, intracranial pressure. Whereas the systemic factors include age, sex, partial pressure of CO2 and hematocrit. And the mean flow velocities are least influenced by hemodynamic factors. So now we have three velocities. So one is peak systolic velocity, one is end diastolic velocity, and one is mean flow velocity. So how do we use them is, we use peak systolic velocities for looking at stenosis. So what happens is, whenever the blood flows through the stenosis, peak systolic velocities increase. So how much peak systolic velocities increase, based on that, we would like to classify the degree of stenosis. So peak systolic velocities are to assess stenosis in the vessels. Whereas end diastolic velocities are to look at intracranial pressure, because when intracranial pressure increases in the brain, the first thing that happens is the end diastolic velocities decrease. So we would like to see how end diastolic velocities are decreasing, and we can tell about intracranial pressures. Whereas when you look at the vasospasm, so when there is a vasospasm, we would like to look at the mean flow velocities as a standard of approach. So this is how peak systolic velocity stenosis, mean flow velocities for the vasospasm, and end diastolic velocities for the raised ICP. So now, as we have talked that, cerebral circulation doesn't happen in isolation. So we would like to see, the factors which is affecting mean flow velocities, which increase or decrease. By the way, like I told that mean flow velocities are least affected by hemodynamics, but compared to peak systolic and end diastolic velocities, mean flow velocities is compared, and it is a bit least influenced by the hemodynamics. So the factors increasing mean flow velocities are hyperemia, vasospasm, stenosis, initial stages of raised ICP, so feeder vessels of AV malformations, collateral vessels, sickle cell anemia. whereas factors decreasing mean flow velocities, hypoperfusion, vessel occlusion, and area distal to stenosis and advanced stages of raised ACP. So with this, we would like to look at certain waveforms. So the picture above is, the waveform is depicting a high resistance waveform. Why? Because you can see that there is a upstroke, but then there is a end-diastolic velocities have been reversed. So this is the end-diastolic velocity and it has been reversed. So this is a classic example of high resistance circulation that happens in the peripheral artery. So you take radial artery, you take ulnar artery, these type of waveforms you get, and this is high resistance circulation waveforms where your end-diastolic velocities either reach baseline or they get reversed. So now if this happens in the brain, it is a ominous sign. It says that raised, the intracranial pressure is very high. So then how it should be? So it should be like the image below where, there is a sharp systolic upstroke, then there is a dicrotic notch and end-diastolic velocities are not touching the baseline. Okay, it is well above the baseline. Okay, so they say that end-diastolic velocities should be at least 30% of peak systolic velocities, and here it is well above that 30%. So we have noticed how high versus low resistance circulation waveforms would be. And then actually I've taken the example of carotid artery. In our center, we would be doing carotid artery examination as well in any neurological neurocritically ill patients. So carotid artery, we've got some classical images where we can demonstrate how stenosis affects velocities. Okay, so now here in this, this is a carotid bulb, and the carotid bulb in the blue color has a plaque. So that plaque is causing stenosis. Now, because the way the blood flows, from here to here, and there is a plaque and there is a stenosis, there is a change in velocities. How it changes, we see. So the first sample is taken before the flow is going into the stenotic segment, and we can see that peak systolic velocities is 71.4 centimeters, and this is the waveform. Now, as the blood enters into this stenotic segment, and we have taken a sample. So here you can see that peak systolic velocities are 184 centimeters per second. So as we have told before, whenever there is a stenosis, by virtue of narrowing of the vessels, so there is a increase in systolic pressure. So peak systolic velocity has increased here. Now what happens is, once the blood goes through a stenosis, once it comes out of stenosis, so there is something called as post-stenosis zone phenomena, and there is a flow disturbance. So we usually have a laminar flow, but then what happens is suddenly, the blood comes into the, out of post-stenosis zone and it dissipates. So the laminar flow is disturbed, and this is how we get a flow disturbance, classically 1 centimeter away from the post-stenosis. And if the stenosis is significant enough, what we get is a dampening of flows. So say that I have sampled it around distal M2 segment, and say that M1 segment of MCA has a severe stenosis. So now the blood, as it flows, when it goes to the M2 segment, it shows something called as dampening. So there is hardly any upstroke. So this, if there is a deficient in upstroke, so then we call as dampening of flows. Now, everyone's favorite, pulsatility index. So pulsatility index is based on a understanding that whenever there is a pulsatility, increase in pulsatility of the vessels, which happens with the raised ICP, so the pulsatility index increases, because the formula for it is peak systolic minus end diastolic by mean flow velocities. So here what happens is peak systolic minus end diastolic. So as you understand that raise in ICP or pulsatility, end diastolic velocities will decrease. So peak systolic minus end diastolic velocities, the number will increase. So as numerator increases, pulsatility index increases. So it is an indirect reflection of increase in resistance in the distal vascular bed. So it is also called as Gosling's PI. It is a difference between peak systolic velocities and end diastolic velocities divided by mean flow velocities. Normal range is 0.5 to 1.1. Values of more than 1.2 are seen in raised ICP. So you can see the above waveform is a normal waveform, but as the ICP increases in the below waveform, you can see that end diastolic velocities have come down. Okay, the peak systolic velocities are preserved, whereas the end diastolic velocities have come down. So this is the first sign of raised ICP, and this is where we need to intervene. So if we don't intervene, the ICP increases and impedes the flow. So now you can see that previously the end diastolic velocities have decreased, but they have not reached the baseline. Whereas here you can see that the end diastolic velocities have reached baseline. There is no end diastolic velocity above the baseline, so it is zero here. Whereas here also, if we have not effectively controlled the ICP, then there is a reversal of diastolic velocities. So this is reversal of diastolic velocities. So unfortunately, if you are unable to control ICP and it hits the ship and the ship sinks. So this is systolic velocity is going down. You can see hardly it is having a velocity of 20 centimeters per second. And, systolic spikes, we call it. And, after this, there will be a cerebral circulatory arrest. So, like one of the most important variable we look at neurocritical care, apart from partial pressure of oxygen, is partial pressure of carbon dioxide. So this is a real case we got. You can see the timing. So this is like 1st of December, and we got it in the 2 o'clock in the midnight. So this patient is a elderly gentleman with traumatic brain injury, admitted for a conservative management for moderate TBI. So now we do, ONSD, we do TCD, and nursing officer is stabilizing the case, and we started doing point of care ultrasound. And when I did this transcranial Doppler, here the velocities have come 133. The mean flow velocities have come 133. The peak systolic velocities have gone 181. So I was worried that he has got a hyperemic response in the brain. And I was worried, but then nursing officer has come with a ABG and it showed a PaCO2 of 70. So during shifting, patient has been hypoventilated. So then we have corrected the ventilatory parameters, and you can see that again we have done a TCD at 345, and we have got a normal waveforms. So the TMAX is 55 for MCA. The peak systolic is 87, which are normal. And you can see compared to the previous ones, so the velocities have increased. Now they have been normalized. So whenever there is an increase in PaCO2, the distal bed dilates, and there will be an increase in flow. So that is why the velocities increase in hypercarbia. And once we normalize it, the velocities come down to normal. So I would like to thank you once again. And these are the basics of transcranial Doppler. In advanced, session, we would like to go ahead with the problem-based discussion where, the real case scenarios which we have encountered, I would be putting them. So we would be discussing vasospasm, hydrocephalus, how EVD can be managed with an ultrasound. Then we can say how we have managed cerebral circulatory arrest, and how TCD has helped us in determining brain death, as a ancillary test. So all this as a problem-based learning, we would, love to discuss in the next session. So thank you.
Okay. Thank you, Sai. I think it was a fantastic description of what you need to understand before you take the probe and insonate a window. Where to look for and what to look for, and what to look for in what situation. This is what we understood today. It's an excellent tool which has been available to medical science for a long time, but its capabilities are only being realized in the last 4 or 5 years or so. It is as important and as valuable a tool as focus and Vexus, whatever you can talk about. So let's look at what happens in clinical scenarios next week, and then we will discuss about the pros and cons after the next class. Thank you, Sai.
Thank you, sir.
Please join us again next week again for a second part of this very important topic. We'll meet you again next week. Have a good day. Bye bye.
Thank you, sir.